Good afternoon, everyone. Good afternoon to all the respected doctors. Hello, I'm Dr. Akash, endocrinologist, and today I'm going to discuss something about subclinical hypo and subclinical hyperthyroidism, especially something about the TFT interpretations. And to be honest, endocrinology slides are almost always very dry. So there is no point in too much looking at the screen. I have included some cases and I would request all of you to participate, right? So basic thyroid physiology, we all know there is a thyroid gland in the neck which is being controlled by the pituitary and then hypothalamus higher up above. So there is going to be feedback mechanisms. Understanding these mechanisms can help us understand the lab values. So T4, T3 are the thyroid hormones. TSH is the hormone getting secreted from the brain. When the T4, T3 levels are adequate, TSH remains fairly adequate. When the levels are underproduced or overproduced, there is a negative feedback. And then we have got lab reference ranges. A very important thing to understand here is that there is an inverse logarithmic relationship between the thyroid hormone level and TSH level. So simplified terms, any small change in T4 or T3 level will give a higher fluctuation in TSH level. So most of the times TSH is the lab value which we are first looking at. Now the first case, challenge for all of us, right? A 62-year-old male right now in ICU, diabetic and had MI, acute MI. Probably we are not often involved with ICU patient care, but some of your patients or their relatives may come with the reports for an opinion, or post-discharge they will bring this kind of reports that this was the scene 15 days ago. So while being admitted in ICU, the patient was found to have relatively low TSH and low free T4 level, right? Both the levels are low. So what are the options regarding the treatment? Should we start with levothyroxine straightforward? Should we repeat the thyroid function test after 2 weeks, or should we go for anti-TPO antibody levels? So B. So I would A, anyone with the A, please raise your hands. Okay, B, great. And C, alright. So here it was very clear that TSH and free T4 both were low, both were going in the same direction. So this was probably a case of non-thyroidal illness, or also known as euthyroid sick syndrome. So whenever a person is very sick, basically the person goes into a catabolic state, and during this catabolic state, body does not need too much of thyroid hormone. So TSH, the brain function as well as the gland function, both start getting to suppressed, and that's why we get lower levels. Best thing to do is that we do not initiate any thyroid anti-thyroid medicine. We wait as the patient's general condition improves. We repeat the test, and most of the times it gets to normal. So next case, a 28-year-old female who is married and she is P0, so no pregnancies in past. Preconceptional evaluation, everything is normal, only TSH is 8, and with that T4, T3 are normal. The gynecologist had asked that wait for a while. She repeated the test. Now TSH is still elevated 9, and she comes to you with this question: what should I do next? So the option: should we repeat the test at every 2 to 3 months? Should we check anti-TPO, or should we start levothyroxine? So A, anyone with the A? Okay. B, option B. Okay, and option C. Great. So option B and C are fairly okay here. B, to have more clarity, anti-TPO positivity is likely to be associated with progression over a period of time. It's not a 100% rule. It is likely, possibility is a bit higher. And starting levothyroxine in a subclinical hypothyroid patient is very much important when we are considering pregnancy plan, because even subclinical hypothyroidism has got certain adverse effects on the fetal growth. So now, coming back to the theoretical aspect, understanding the bell-shaped normal curve. So when we plot the normative, when we try to plot the normative data, when we collect TSH values from all of us, and then we look at what is the normal range. So we typically say 95% of people are falling into normal. On both the side, 2.5%. Although they have normal T4 and T3, that TSH is likely to cross the normal reference range. So lower TSH with normal free T4, free T3 is considered as subclinical hyperthyroidism, and higher TSH with normal free T4, free T3 is considered to be subclinical hypothyroidism. Now, to call someone or to label someone as subclinical thyroid disease, it has to be sustained. One single result is not sufficient to call someone as subclinical thyroid disease. So levels should be repeated as and when needed as per the patient profile. Now, TSH is a molecule, TSH is a lab value which gets influenced by many different factors. No point in mugging up all of this, but this can give us a lot more clarity, when we cannot explain certain kind of fluctuations, certain kind of lab results and patient's clinical profile, if they are not correlating. Look at all the different parameters, look at all the different possibilities. So those could be age related factors. Higher age and obesity are known to have higher TSH levels. And then there are certain medications like calcium supplements, iron supplements. Then there are certain lab errors or interfering molecules. So those could be one potential explanation for higher TSH value. Similarly, for a lower TSH value, there are probably certain explanations like first trimester of pregnancy is known to have low TSH levels. Then certain ethnic changes or certain medications, especially glucocorticoids at higher doses. We often use steroids, right? So those can lead to TSH suppression. So now with TSH, it is very much essential to understand T4 and T3 changes as well. So there are certain medical conditions, there are certain medications and certain interfering substances which can lead to simultaneous changes in free T4 and free T3. So this is a very busy slide, very difficult to memorize everything. I would just always ask that whenever you feel stuck, whenever TSH and T4, T3 are not behaving in a typical fashion, try to consider looking at all the different factors, try to dig deeper, right? So this is somehow a kind of summary of different kind of result interpretation. So in the center we have the normal values. Here low TSH and higher free T4, free T3, that is a typical hyperthyroid picture. And we all know the causes: Graves' disease and thyroiditis, transient changes and many other causes. Then this is a typical hypothyroid. Primary hypothyroid could be post-radiation, could be post-autoimmune disease, could be post-surgery. And then there are certain other differentials also which are very unusual. Now this is the difficult area: subclinical hyperthyroid and some other differentials, low TSH and normal T4, T3, and similarly subclinical hypothyroidism with certain difficulty. So I would just like you all to know that there are many differentials. We always have to look deeper, right? Look at the patient clinically, try to correlate multiple different factors, symptom wise, thyroid gland examination wise, etc. Now, when do you call it subclinical hypothyroidism? Higher TSH, normal free T4, T3. It's a misnomer, right? When we call it a subclinical disease, we expect something wrong is going on, but most of the times patients do not have any specific symptoms. And in terms of progression, right, let's say we are chasing all these patients, we have thousands of subclinical hypothyroid patients right now. If we chase all of this over a period of years, 10 years, 20 years, what happens to those patients? How many of those go into actual hypothyroidism? How many of this come back to a normal thyroid status? So almost 60% of cases, they revert back to normal thyroid status over a period of 5 years. And the progression to overt hypothyroidism, that is somewhere around 1 to 5% per year. So progression is very low. So considering the Indian data, various studies have reported various prevalences. It can range from somewhere around 8 to 15% of apparently normal population. And not going detailed in depth of causes are somewhat similar to all the hypothyroid causes. In terms of symptomatology, so even when we look at the frank and obvious hypothyroid cases, symptoms are almost always non-specific, right? Weakness, constipation, fatigue, excessive somnolence. So these are all probably overlapping with many other diseases. Similarly, symptoms in subclinical hypo are also fairly non-specific. Also, there were studies which showed that those completely normal population in the study, out of those 33% had kind of similar symptoms. So based on the symptoms, again, it is difficult to decide who needs treatment. Now, very important question about anti-TPO antibody. We all advise anti-TPO antibodies every now and then. To understand about anti-TPO antibody, it's a completely different subject and in-depth science. Just a bottom line is that don't chase anti-TPO antibody levels. If you want to get it done only once in lifetime, right? If it is elevated, you can only assume that patient is at somewhat higher risk of developing thyroid disease. If it is normal, still the patient may develop thyroid disease. So practically speaking, it does not make much of a difference except for very specific scenarios. Let's say we are using this level to prove some other autoimmune disease, right? Some other joint disease or some other rheumatological condition where we are not able to pick up the specific antibody, and we are trying to utilize this as a surrogate marker. That is one. Second, of course, young female planning for conception and some clarity is not there what to do next. And third, someone who is experiencing very labile TSH, not very commonly seen, but someone having today level is normal after 3 months, maybe 8, 9, 10, after 3 months again normal, and then those kind of repeated fluctuations, maybe their TPO antibody could be of help.
So 4 minutes left.
Right. So what happens with subclinical hypothyroidism and cardiovascular events? So there is somewhat higher risk of developing certain cardiac events. And what happens if we treat versus what happens we do not treat? So those age below 60, 40 to 60, they showed improvements in cardiovascular outcome when treated for subclinical hypothyroid, whereas those aged more than 65 or 70 did not have significant improvements. So age is a very important factor when we are choosing whether to treat a patient of subclinical hypo or not. So right. So there are certain guidelines, and each society has got different approaches. We all need to individualize our treatment protocol. So factors that favor observation in a patient of subclinical hypothyroid, that includes relatively older age, normal lipid profile, absence of metabolic syndrome, no heart disease, TSH values typically remaining below 7, and obesity. And then there are factors which favor treatment over just observing. So positive TPO status, certain symptoms probably related to hypothyroid, age below 65, TSH values more than 7 typically should be treated. So there are 3 steps approach to understand and pick up patients very carefully. So first you ask about the certain confounding factors, the age, obesity, the other assay interfering substances and all. Then you consider repeating the measurement over 2 to 3 months, SOS anti-TPO antibody level, and then you choose. So this is the crux of subclinical hypothyroid, when to use levothyroxine, right? It's a very simple thing. About 10 you treat the patients, 7 to 10 maybe you treat all, below 7 maybe you treat younger patients, not the elderly. Now the other aspect of subclinical hyperthyroidism, TSH suppressed below 0.4 and T4 T3 normal. Now etiology could be again earlier stage of hyperthyroid disease, or a transient fluctuation, drug related maybe, or there are many other etiologies like multinodular goiter as well. So the prevalence of subclinical hyper, it's a different spectrum now, and there we can see around 0.7% having very low levels of below 0.1 and around 1.8% having 0.4 of TSH value. Now prevalence has been found to be even higher in certain areas where there is iodine deficiency and age more than 70 years. So let's get back to again cases. It's time to wake up, guys. Sorry. Case 3, a 63-year-old male woman who had this multiple sclerosis progressive and was referred with this kind of thyroid profile, very low TSH, very high T4 T3. Now surprisingly on clinical examination, no hyperthyroid features, no significant goiter. So we had a suspicion what to do. So the next possible step, should we recheck the levels? Should we go ahead with anti-TPO levels? Should we go for a USG neck? Option A. Right. Anyone with option A or B? No. Great. Now looking again in depth. So we found that the patient was taking very high dose of biotin for the potential benefits, right? We always give certain kinds of supplements in certain illnesses. Now biotin is a substance which is known to have assay interference. So a very high biotin level in blood can lead to very low TSH and very high T4 T3 level in anyone, any of us, right? So what we did was we gave a washout period. Usually 6 to 8 hours is something fairly okay, or 24 hours. You stop the biotin for a day, you repeat the test, and it is likely that the test will come back normal. So repeating the test after stopping biotin was the best option, and that we did, and we found that patient did not have any thyroid disease. Now a different case, another 63-year-old female. Just give me 2 more if you want. Fine. So another 63-year-old woman and history of atrial fibrillation, episodic, could not find any obvious causes except for low TSH and normal T4-T3. So a patient with atrial fibrillation and subclinical hyperthyroidism. Option A, should we check for total T4? Option B, should we go for TSH receptor antibody? Option C, should we go with the US ZONAL? Or option D, antithyroid medication? Right. For those who do not know, TSH receptor antibody level is a very specific test antibody for hyperthyroid Graves' disease, but it is a very costly test, so we don't advise always. US ZONAL is not very useful except when we find a nodule or something. So this is atrial fibrillation probably related to subclinical hyperthyroidism, and treating might be beneficial. So this is again a flow chart. You can all take a snap if you want, and you know, it's a very simple flow chart where if levels TSH is low with normal T4, T3, you may consider TSH receptor antibody or a scan, or you may recheck the level over a period of time, and you can decide accordingly. So if the levels are elevated, you stamp it as probably Graves' disease early stage. If the levels are normal or radioactive, this technetium uptake is there, again hyperthyroid. If levels are normal with uptake in a focal area, could be a nodule, and you know, if levels are almost normal with no uptake, then thyroiditis is something you are dealing with. So a different case scenario, a woman relatively asymptomatic, low levels, what should we do? Right? Different from other cases, no symptoms, should we treat or not? Okay, so what if we do not treat? What are the possible outcomes? If we do not treat a subclinical hyperthyroid, one is patient may go on to develop frank hyperthyroid over a period of time, or some of them even revert to normal or hypothyroid status. Then there are, even if the patient remains in a subclinical hyperthyroid state for a few years, it is likely that patient is going to develop some adverse cardiovascular event. So risk of atrial fibrillation, risk of tachycardia, loss of heart rate variability, those are all reported. And also worsening of osteoporosis and osteopenia is something we all know. So this is again a bottom line when to treat for a subclinical hyperthyroid, right? Any symptomatic patient may be considered for a treatment with TSH below 0.1, and age more than 65 with TSH below 0.1, yes, they are eligible for the treatment. So last case for the day from my side, a 26-year-old woman, 2.5 months of amenorrhea, low TSH, normal T4, T3. Option A, should we start antithyroid drugs? Option B, repeat the test after a month. Option C, thyroid uptake scan. So clinically, patient in pregnancy, it is a bit difficult to differentiate clinically, but there is no goiter, right? So this is probably Graves or not? Query. Starting antithyroid drug has got grave implications at times. So if we are falsely treating, erroneously starting antithyroid, then we are putting patient in a major compromised state. So it is always advisable that hypothyroid, subclinical hypothyroid should be treated well in pregnancy, but hyperthyroid, do not be in a hurry. Take a day off. Ask the patient to get tested again, ask a patient to go and see someone else, or ask the patient to get antibody levels done, TSH receptor antibodies. If that can be done, that can give us more clarity at time. So this is the conclusion of the slides. Thank you.